about the important,
Sorry.
important and timely issue of healthcare access and affordability in Ohio and exploring the challenges with upcoming policy changes. I'm Amy Rowley McGee. I'm the president of the Health Policy Institute of Ohio. And again, we're glad to have all of you here with us today. I am off camera because I'm on the road and I'm having some computer difficulties, but I am here and happy to be the moderator of today's session. The vision of the Health Policy Institute of Ohio is that Ohio becomes a model of health, well-being, and economic vitality. And our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in our state. Next slide. Thank you to all of our funders who support our work. They make it possible for us to host webinars like the one you are attending today and to produce the publications, some of which Brian will be highlighting here shortly. Next slide. And thank you also to all of our educational event series sponsors. These sponsors supported our Health Policy Summit 2 months ago and also support the webinar series. Next slide. Our organization has put out a number of publications over the last several months exploring issues related to healthcare access and affordability. Here's a QR code that you can scan to access the landing page where all of these publications are posted. Brian's going to touch on some key pieces of data from a few of these publications here today, but there's much more information available in them. So please take a moment to review and share them with others who may be also interested in learning about these topics. Next slide. Brian. Oh, there we go. Our speakers today are Dr. Brian O'Rourke, who's a healthcare policy analyst at HPIO, Grace Wagner, who's the Director of Health Initiatives for the Ohio Association of Food Banks, Rose Freck, who is Director of External Affairs for Integrated Services for Behavioral Health, and Summer Kirby, who's the CEO of Compass Community Health. As our speakers are presenting, please feel free to type questions into the chat or question box, and we'll address them as time permits. We're also going to have some polling questions for you at the very end so that we can evaluate the quality and content of today's webinar. So please stick around and respond to those few questions when we conclude. Today's presentation slides will be available on the HPIO website. Again, here's a QR code for you to scan to get access to those slides and other resources that are available on the events page. And now I will hand it off to my colleague, Brian.
Awesome. Thank you, Amy. Hi, everyone. My name is Brian O'Rourke, and I am a healthcare policy analyst here at HPIO. And today I'm going to present some important findings and highlights from our healthcare access and affordability series, which started in August. The purpose of this series was to understand how upcoming policy changes, particularly key provisions in HR 1 or the One Big Beautiful Bill Act, are likely to impact the ability of Ohioans to find health coverage and access healthcare services. I first want to give you some context on the current landscape in the state and how healthcare affordability intersects with overall cost of living pressures for many Ohio families. As some of you probably already know, Ohio's uninsured rate has dropped substantially since 2010, in large part due to components of the Affordable Care Act, and we tend to have a better than average uninsured rate compared to other states. While about half of working age Ohioans receive health insurance through their employer, another quarter are covered through the state's Medicaid program. And there are also other important sources of coverage in Ohio, including ACA marketplace plans, which I'll talk a little bit more about later. A key part of our low uninsured rate is our adoption of Medicaid expansion following the passage of the ACA. This category covers nearly 800,000 low income Ohioans today, which is about 7% of our total state population. And I highlight this information because HR 1 includes many provisions that will affect Ohio's Medicaid program and the expansion group in particular. Despite our relatively low uninsured rate, current data suggests that many Ohioans still struggle with accessing health services, specifically because of care affordability. So in 2023, about 1 in 5 Ohioans said they had trouble paying off medical bills in the last 12 months. While this rate is higher amongst uninsured individuals in general, people with insurance also frequently struggle with medical bills in the state, including over a quarter of individuals with employer-sponsored health insurance in Ohio. The cost of health services for Ohioans has risen consistently in recent years. On the left side of the slide, you can see that median medical spending for an Ohio family in 2023 was $2,680, which exceeds the national median by over $700. Insurance premiums in particular have become a pressing issue for many Ohioans, especially because they have also been consistently increasing year over year. For employer-sponsored coverage, the average premium that the consumer must pay exceeds $6,000 a year on average for a family plan, as shown on the right side of the slide. Many plans also have high deductibles, which are the amount that must be paid out of pocket before insurance begins paying for services, in addition to those monthly premiums. Lower income Ohioans who receive insurance through Medicaid tend to not face these high levels of out-of-pocket spending. However, if they were to lose coverage, many would struggle to find alternative sources of insurance and would potentially lack the resources to afford health services. That's just an important thing to note, especially as I go through some policy changes that are coming up later in this presentation. The trends that I just talked about related to the cost of healthcare and difficulties paying medical bills intersect with ongoing issues that Ohioans face with the cost of living. So health expenditures are only one component of an Ohio family's budget, which will also include housing, food, childcare, and more. The United Way estimates that a family of 4 with 2 young children in childcare needs to earn at least $79,224 a year to afford all their essential needs in Ohio, including healthcare. If the cost of care or other necessities continues to rise, it will continue to strain Ohioans' budgets and potentially lead to difficult decisions, like choosing between buying food for the week or seeing a doctor for a health issue that develops. Now that I've covered the current Ohio landscape surrounding care access and affordability, I want to move into the major upcoming health policy changes affecting our state. Many of these come from the Federal Reconciliation Bill, HR 1, or the One Big Beautiful Bill Act, which was enacted in July of this year. HR 1 included major changes to Medicaid and other sources of insurance, such as the ACA marketplace. And there are also other ongoing policy decisions that will affect access to ACA marketplace plans that I'll discuss as well. Because of these provisions contained in HR 1, Ohio is expected to lose approximately $33 billion in federal Medicaid funding in the next decade. While projections vary a bit, some estimates suggest that this will cause an additional 340,000 Ohioans to become uninsured. So given the healthcare affordability and cost of living pressures already facing many Ohioans, this is likely to have major financial and health effects for individuals and families in the state. Oh, I'm sorry, I went extra slide. So I previously mentioned about 800,000 Ohioans currently receive insurance coverage through the Medicaid expansion category. HR 1 mandates that in order to keep their coverage, Medicaid expansion enrollees must comply with new work and community engagement requirements. So essentially, they must complete 80 hours of work, educational programs, and/or community service per month or meet a limited set of exemptions. Exemptions include parents of children under the age of 14, people who are medically frail, and people who are undergoing substance use treatment, along with a few other small categories. This provision alone may cause up to 200,000 Ohioans becoming uninsured. Evidence from states with previous Medicaid work requirements suggests that these disenrollments are frequently caused by administrative barriers, like issues navigating online portals to upload verification documents, rather than failure to actually meet the requirements themselves. While Ohio will use external data sources for automatic verification of compliance where possible, some enrollees will most likely need to submit documentation themselves to prove that they're in compliance with the requirements or meet one of the exemptions, which can be logistically challenging. Importantly, before H.R. 1, Ohio had submitted a waiver to the Centers for Medicare and Medicaid Services to implement work requirements, though this proposal included key differences, such as exempting people over the age of 55. As you can see in this timeline, Ohio intended to implement their work requirements proposal by the middle of next year. H.R. 1 mandates that all expansion states implement their work requirements by the end of 2026, but with the possibility of delaying until the start of 2029 with approval from the federal government. Given Ohio is already preparing to implement their own work requirements, it's not currently clear when they will begin in the state. Ohio policymakers also have to make other key decisions in the coming months, such as whether to include optional hardship exemptions for people living in counties with high unemployment rates or recent natural disasters. I also want to mention briefly that in addition to work requirements, H.R. 1 also requires more frequent eligibility determinations for the Medicaid expansion population, going from once every 12 months to every 6 months. So this could lead to additional administrative burdens for both enrollees and county governments that process those enrollments and verifications. Another important H.R. 1 change is that states will be required to impose cost sharing of up to $35 per service for the expansion population. So some services like primary care and substance use disorder treatment are exempted from cost sharing, but KFF estimates that this could cost enrollees over $500 a year, which is a substantial amount for many lower income families. We recently released a data graphic showing that over half of Medicaid enrollees in Ohio currently struggle paying household expenses, meaning that additional healthcare costs could put major pressures on their budgets. Policy changes like this cost sharing provision could again lead to difficult financial decisions for many Ohioans. And this is another area where state policymakers will need to make important upcoming decisions, including the exact cost sharing amount per service, which is not clearly specified in H.R. 1. Perhaps the biggest impacts from H.R. 1 are the changes to Medicaid financing, which are complicated but are going to have major implications for Ohio's Medicaid program in the coming years. HPIO is going to be covering these changes in depth in a policy explainer that comes out early next year. For example, H.R. 1 includes new restrictions on provider taxes, which are a mechanism that almost every state in the country uses to generate revenue for their Medicaid programs and draw down federal funds. Ohio is going to face particularly strong impacts from these provisions because we are one of 7 states with a provider tax on managed care organizations that will be prohibited entirely moving forward. Based on the recent release of federal guidance, these restrictions will affect Ohio's Medicaid budget sooner than expected. Other financing changes include new caps on state-directed payments, which Ohio and other states use to enhance reimbursement for providers who see many Medicaid patients. And they're one of the ways that revenues raised by provider taxes return to providers to help compensate the cost of care. And finally, you might have heard of the Rural Health Transformation Fund. This is a one-time funding source of $50 billion in H.R. 1, half of which is divided evenly across the states, and half of which will be allocated to states based on rural population size and state applications. So Ohio recently submitted their application, and it's prioritizing initiatives such as school-based health centers and expanded scope of practice for pharmacists, amongst many other things, to alleviate issues with rural healthcare access. States are going to hear back by the end of this month about year 1 funding. And importantly, this funding source will not nearly make up for the total losses in federal Medicaid dollars from H.R. 1, even if Ohio's application is viewed or scored very favorably. The number I showed at the start for H.R. 1 impacts was $33 billion in reductions in federal funding for Medicaid in Ohio over the next decade, taking into account all of the H.R. 1 provisions. Policymakers in the states only have a limited set of options to account for this shortfall. That includes reducing reimbursement rates to providers, eliminating optional cover services from the Medicaid program, like prescription drugs or some types of mental health care, or cutting eligibility groups such as the Medicaid expansion category. So far, I've covered a lot of policy changes specifically affecting Medicaid. One key component of H.R. 1 that affects Medicaid, but also other health programs, are restrictions to program eligibility for certain immigrant populations. Some groups of immigrants, including refugees, asylees, and survivors of domestic violence and human trafficking, were previously able to access health coverage through programs like Medicaid and Medicare, subsidies in the ACA marketplace, and nutrition benefits through the Supplemental Nutrition Assistance Program, or SNAP. H.R. 1 narrows the categories of immigrants eligible for these programs, meaning groups like refugees and asylees will no longer be able to access health coverage through Medicaid or food support through SNAP. There's important nuance across these programs, and some groups of immigrants will remain eligible, but these provisions overall will have broad financial and health consequences for many Ohio immigrants. One last policy change I want to highlight that's not related to H.R. 1 directly is the expiration of enhanced subsidies for ACA health insurance marketplaces. For those who don't know, ACA marketplaces were set up as a place to shop for and purchase insurance plans when they did not have coverage through their employer or a program like Medicaid. Some groups frequently access insurance, who frequently access insurance through the marketplace include people who are self-employed, as well as farmers and ranchers. As part of the American Rescue Plan Act in 2021, Congress created enhanced subsidies to make these plans more affordable to consumers. That resulted in many more people getting coverage through the marketplace, including in Ohio, where enrollment increased by over 300,000 in the last 5 years. And so today, 580,000 Ohioans get health insurance through the marketplace. These enhanced subsidies expire at the end of this year, and without an imminent extension, premiums for marketplace plans are expected to double or more in 2026. Many Ohioans have likely already seen these increases when they went to shop for or renew their plans on healthcare.gov. And for some individuals, this can mean annual premium increases of $3,000 or more. The expectation is that many people will choose to forego coverage because they cannot afford the premium increases. And the Urban Institute estimates an additional 140,000 uninsured Ohioans next year due to the expiration of these enhanced subsidies. Given that we're now in mid-December, an extension is seeming less likely before the end of the year. To see the work we've done in this space, visit our Healthcare Access and Affordability Projects page on the website. This is also where our upcoming work will be published as we continue to evaluate how state and federal health policy changes will impact Ohio individuals and families. My contact information, as well as Amy's contact information, are available here if you want to reach out with any specific questions about this work. And now I am going to turn it back over to Amy to moderate a discussion with our excellent panel members about affordability and policy changes.
Brian, please type your questions for Brian in either the chat box or in the Q&A box. While our panelists are discussing these topics further, he will keep an eye on the questions and respond to any, and I will as well. And as our panelists are speaking, please go ahead and put in any questions you have for them in the Q&A or chat box too. All right, so let's kick off our panel discussion. Rose, Summer, and Grace, thank you so much for being with us this afternoon. I'm wondering what are the policy issues that are having the most significant impact on the ability of Ohioans you serve to access what they need to be healthy. And I'll just let whoever would want to go first speak first.
Good morning, everyone, and thank you for the opportunity to be alongside such wonderful panelists. I know that you mentioned that I am the CEO of a community health center, Compass Community Health, but I also have the pleasure of serving as the chair of our state primary care association. So, as I come together with some responses, I really want to try to give you some feedback from that overall perspective versus just a singular health center. So, part of the concern is what we have experienced so far really doesn't reach the depth of what we are about to experience. When we talk about, the legislative changes and the budgetary changes, we know some of the things have been felt so far for those that we serve kind of collectively in our Ohioans. However, it just really hasn't taken full effect yet. So, for example, some of the cost sharing mechanisms for those that have Medicaid coverage, for an individual to be responsible for a copay is kind of what we're used to calling it, right? So for us, maybe we just, in some respects, try to refer to it that way so that we feel like it's a little bit different, and we prepare internally what that means, or explaining that, to the patient that we're serving. If an individual all of a sudden now has $35 that they're responsible for a visit, that's going to be significantly impactful, and they have not yet experienced that. So that, I think, is one of the things that we recognize as we're in this closure of 2025 moving into 2026. And so some of the things that we have definitely seen that have been impactful was with the federal shutdown. Individuals were very much so impacted with SNAP benefits, Head Starts closures, maybe expenses towards daycare assistance, regardless of whether children were receiving services in the Head Start setting. And so very quickly we have seen where patients in the community health center space that work received that notification. It led to panic attacks, high increased anxiety already. With that kind of differential, there were experiences where medication affordability just was not an option. So we did have individuals already deciding between food, medication, can I go to work, how do I balance this with my children, because what am I going to do with childcare? So those all have been very much so present in the health care provider patient setting. And so those are some of the things we're initially seeing and trying to address with a patient. And the only way we can do that is collectively as a group, and collaborations and partnerships, because not any one of our organizations can address all the needs, and they're so extensive with the patients that we serve and our fellow Ohioans that are experiencing this.
Okay. Thank you. Thank you for sharing that, Summer. How about you, Rose?
Yeah, hi everyone. Thanks for being here to listen to us today. So I think the changes to Medicaid are really front and center for us at Integrated. If you're not familiar with our work, we are a community mental health, substance use disorder treatment, and housing organization. And Medicaid is the primary payer for the nearly 15,000 people that we serve for mental health and substance use disorder treatment across Southeast and into Central Ohio. So those work requirements, those more frequent eligibility checks, not only are they likely to lead to coverage loss, like Brian mentioned, but we're also anticipating there'll be significant churn where people are coming on and off coverage regularly. And obviously that's very challenging to manage as a business. But more importantly, when you're thinking about care, having to abruptly end treatment for somebody who maybe is engaging in something like medication for opioid use disorder, that becomes really life-threatening. So, that stuff in combination with kind of the ongoing concerns about the state budget constraints that could drive reductions in rates or covered services, all of that, I think, is going to be really destabilizing to behavioral health providers, because we already operate on these very, very thin margins. But I also just wanted to mention, when we think about the work requirement and the eligibility checks, some of that's going to be felt really intensely in rural and the southeastern part of the state. We are operating in an area where there's very limited job availability. We know folks are often traveling really far distance. It's not uncommon for people to drive from Meigs or Benton County to have to find employment. Very limited access to public transportation. Technology and broadband gaps. All these things in combination are just going to make it harder, even for people who really want to meet the requirement, or who are out there trying to find work. It's just going to make it harder for them to do so. So then, what we know is that when people lose access to health insurance, or they have to move to more expensive coverage, mental health, substance use disorder treatment is often some of the first stuff to go, right? Because it's sometimes seen as not essential. But the trickle down effect of that, when people who need mental health care or need substance use disorder treatment no longer have access to it, I mean, we're going to see that show up in other parts of our communities. And then the one other thing that I would just be remiss not to quickly mention are the changes we're seeing at HUD. Integrated is also a permanent supportive housing provider. HUD has recently announced some changes to their funding priorities, which would shift funding away from permanent housing options towards more short-term and transitional options. And this includes for people who are struggling with, serious health conditions. If you've been following along with that, the funding announcement that created that change is currently on pause. There's active litigation, but there's still generally a belief that this is the direction that HUD wants to go. And I raise that because we know stable housing is so closely connected to health outcomes, that this is just going to be kind of another strain. So I think, just to Summer's point, I think these things are things that families are experiencing really in the compound, even if we're experiencing them kind of separately as siloed systems. Yeah, I would say those are things kind of front and center for us as it relates to policy change right now.
Thank you, Rose and Grace. What recent state or federal policy changes have you or your members found are having the greatest impact on the people you serve?
Yeah, many of the things that Summer and Rose have already said, we are seeing across our network. In my role as the Director of Health Initiatives, I oversee some federal health insurance enrollment programs and work closely with other public benefits outreach and enrollment. And, we are days removed from the federal shutdown and still coming out of crisis response mode across our network, and seeing the impact of lack of access to SNAP, hard to move forward from that. So we are really concerned about the eligibility changes for Medicaid and SNAP and the loss of premium tax credits. And as Rose said, how those things interact with each other. When someone is experiencing hunger, that's likely not the only challenge that they're experiencing. It coincides with housing limitations, transportation, broadband access, all these things work together. And during the shutdown just a couple of weeks ago, those first few weeks in November, our network saw a 46% increase in the amount of individuals coming to our emergency food system. And we were already strained on our ability to meet the need of the community, because it's grown substantially over the last several years as inflation and cost of living has risen. So, just getting that small couple of weeks of SNAP benefits being paused and anticipating what the response is going to be in the community when eligibility changes happen with Medicaid. Some eligibility changes have already happened with SNAP. There's a lot of confusion. There's a lot of stress in the community, and that is showing up for sure with our application assisters and people coming not just to receive food, but because they are in crisis and trying to navigate that on top of being an emergency food system and providing that first level of need. And but again, many of the things that Summer and Rose have already said, we are keeping an eye on that as well.
Well, and I saw a question come into the chat box that somebody asked when will consumers see the changed premium amounts on the marketplace, there is so much uncertainty that I don't know what to tell my clients when assisting them with choosing insurance. Brian responded to the question, but what stood out to me was there is so much uncertainty. I don't know what to tell my clients. And that seems like a consistent thread across what all three of you said, that it's very confusing right now. I mean, I think all of us who are in the field, we're getting paid to stay on top of these things. And it's hard for us to stay on top of every new development, let alone people who like are living lives and working in professions that don't have anything to do with any of this. Like how, I guess, I mean, you probably are still figuring this out, but like, what do you think would be most useful for the people you serve in terms of tools to explain these changes? Or have you found anything in particular that's working in terms of explaining all of the things that are happening?
So I would probably just chime in with some of the approaches that we've tried to take because yes, there's a lot of uncertainty. And I would add the reminder that it is also quite a divisive time. So individuals' opinions in terms of trying to share information also very much so comes up, or it can be perceived as it means you are pro or con against a particular item. So we kind of consistently try to level set and say, hey, this is going to hit some of you differently. And we try to take the approach with patients like, let's just share some information. Did you know? Let us help and explain so that individuals can also make their own assessment for maybe how it's going to impact them. Because the level of uncertainty currently exists, even for one of the things that comes to mind is an individual may come in today and it shows that they have coverage. They go to get a prescription and they're covered by Medicaid and the prescription should be covered, but then it shows that they don't have prescription coverage. And come to find out, system updates haven't fully, translated and they no longer have that medical coverage. So they're dealing with these kinds of things with trying to also understand, all of these new eligibility requirements, whether I'm ineligible now and I haven't been previously, or what the new standards are. So it is so hard for those of us that are working in it to maintain kind of up to date with what's going on. So the best thing that we've sort of found is educate our team, share with our team, be available, use kind of basic terminology that people can relate to and show what other resources are available because we're not going to have the answers to all of the things when it comes to being a permanent housing provider or food assistance. So making sure that we've got contacts with other organizations so that we can really help funnel the right person, the right information. Try to make sure that patients, individuals that we serve have access to know what doors to open so that they can get to the best resources possible within all of our settings, and really trying to use good generalized information that might start with, do you have a question about your coverage? Or do you have a question about, SNAP benefits? Because when we list that with so much other information, it's easy to get lost in translation. And in some of the areas, we have gaps in understanding like health education and those kinds of things. And so really just trying to navigate a person to where they can go to connect with a human being to get subject matter information.
Okay, great. Thank you. That was really helpful. Others?
Yeah, definitely echo everything Summer said, standing in partnership and in coalition with other agencies and organizations across the state and not trying to be the expert in all of the changes that are coming is something that, we're trying to do. Something just to elevate another consideration, we are weighing information paralysis of like, what do our neighbors need to know today, and how can we communicate that in the plainest possible language? So I know that in 2027, things are going to be happening in Medicaid, but is that important for someone to know today when they're facing
Mm,
questions about their SNAP benefits or about HEAP or, other things? And not that I'm trying to dictate what's important to our neighbors, but I'm just trying to present as accurate and timely information as I can when we have it, so that we're not creating speculation or potentially, stoking fear unnecessarily. So that's something we have been weighing quite a bit, both during the shutdown and as we see some of these policy changes on the horizon. Like, what do we really need to be saying in this moment? What do neighbors need to know? And how can we make that available in a variety of languages when that's available to us? How can we distill down notices neighbors might be getting from state or county agencies, put that in plain language, and be partners with the state in communicating that out through our network?
okay. And Rose.
Yeah, I agree with Grace completely. I mean, it really becomes almost an ethical challenge and an ethical exercise, because I tend to believe that, folks who are engaging with these systems and relying on these services are just like me, and that they want the information they have so that they can make a budget and a plan. And so I think there's that piece of it, right? Which is, if this is going to impact your housing, and maybe there's only a 50% chance it's going to impact your housing, I would probably want to know that. And so I want to assume that other people probably want to know that too. But, Grace's point is incredibly valid too, which is, we are seeing so much, HUD is a great example, right? It's like, we're going to put this out, we're going to take it back. Maybe we'll put it back out. We don't know. And so, there also is that, we, especially when we're talking about with people who do struggle with a mental illness or a substance use disorder, there's always that concern that we don't want to stress people out unnecessarily. What we have been doing for the last many months, as we've been living in this kind of period of uncertainty, is we do a ton of provider education. I host regular policy updates meetings for our teams. We do probably over communicate with our providers around this stuff, because the way that our service model works is, most of our staff are really deeply embedded in communities and are really deeply embedded in the lives of the people they serve. And so I think, like, to Summer's point, they are the trusted person in that person's life. And so I think they're going to actually respond better to their case manager or, community health worker or whatever, than they would to a flyer in the mail or something they see on TV. And so we really try to take the approach of, let's empower our providers with information, with language that is simple and easy to understand, so that they can help deliver that message, and also to deliver it in a way that, is trauma informed, and that reflects that, people are going to, some of this stuff is really going to be hard for people to navigate.
Okay. Well, let's go to talking about the policy environment itself and what we're communicating to our policymakers, whether they be at the state level or at the federal level. So if you were, which I'm guessing all of you do from time to time, sitting down with someone who serves in the legislature, serves in Congress, or works in a federal or state agency, and you could tell them one or two things that you think they need to know about the barriers the people you serve are experiencing to getting what they need to be healthy, and affording what they need to be healthy, what would you share?
I have two, but I'll say them really quick.
Okay.
So I think, and I've thought about this quite a bit, one of the things that I think is really important in this time that we're in, that I would tell policymakers, but also like other decision makers at the state agency level, and even with our managed care and payer partners, is that, as we enter this time that we know will be a leaner time, and as we're navigating these new policy changes, is to please, engage community-based providers in the implementation of those changes and as those decisions are made. I mean, like our teams spend their days in the homes and schools and communities of Medicaid members and of people who rely on these programs and services. And I think, we can really be a thought partner in how we can operationalize those rules and even find ways to be more efficient and effective in the system, but in a way that, reduces avoidable coverage loss, that mitigates harm in the most way possible. And so, I think the more that we can be brought along as partners, all of us we've been doing this work for a long time. And so we know that there are times that are leaner, there are times that are less lean, and we can recognize those constraints. But I think if we can be brought along as partners, we can come up with solutions collectively that will reduce harm in the most way possible. Thinking about that, like specifically as an example, as we see the rollout of the work requirement for Medicaid, there are going to be nuances there that are really important details around exemptions, around reporting, all that kind of stuff. That could be the difference between whether somebody keeps their coverage or not. And so, we really want to be partners on that. And then the second thing is just, I think, the necessity to protect really high value community-based services. We have this really well-developed network of peer supporters, care coordinators, case managers, that has been built over the past couple decades. And these are folks who are really, again, deeply embedded in the community. These are relatively low cost, really high value services. They're cost savers in terms of keeping people out of the hospital, keeping people out of the justice system, keeping families together. And I mean, especially in rural communities. But I think like as the state faces fiscal pressure, I think it's critical that we really think about the long-term returns of those kinds of services that help to keep people safe and well. Sometimes I think they can kind of be, cast aside as less important or easier to do away with. But really they are like the value that you get from those services in terms of giving communities the tools to take care of each other. I think it's unmatched. So I would really suggest that policymakers, do what we can to preserve and protect those kinds of services.
Okay, thank you. Summer, what would you say to a policymaker?
Right. I'm gonna kind of segue from something I believe, Rose, you mentioned earlier about effectively the razor thin margins that our organizations are operating on, and that's pre-making some supplemental lean cuts. And so having that conversation that Rose mentioned is absolutely crucial, because when we have four legs of a stool that makes programs operate, and we have three, with different legislative approaches that are being cut or aren't there, how stable is the stool on one remaining leg? And right now, this one remaining leg's also changed or is uncertain. And that's very much so from a high level, kind of where the community health center space is, not just in Ohio, but overall. So, from a very high level, when there is the uncertainty that many of our programs are experiencing, right? It's not just in the community health center space, but just to put a frame of reference in the community health center space, 340B discount drug program, enabling people to be able to afford medications. When you couple eliminating or modifying that and reducing that with grant funding going away, with the addition of some of the other expenses with programs being put into place, what that translates to is individuals not being able to gain medications, and then all of the other things that we know, right? I mean, Rose and Grace have talked about housing and have talked about food. And we know that job employment was also mentioned. When we start stacking all of these things up, we know that translates to individuals who have challenges with gaining employment. And even if they can't access, preventable or ongoing healthcare services, they're going to end up in an emergency room or urgent care. So let's sit down and talk about the ways that we can kind of manage that. So having some consistent stability, because, these shorter term approaches to continuing resolutions and shutdown has taken this razor thin margin and this very fragile system and made it that much more unstable. And so those are really the pieces that we've been trying to talk about, because everything's been changing. We've tried to, just within my health center, I try to take the approach of eliminating some of the noise, because to the point that Rose and Grace has made, we don't need to talk about 2027. We have people who are just trying to survive today. And how do we get through today to build to, let's talk about a week, let's talk about a month, and move forward from there. So really trying to kind of hone in on what can we address current time, try to make a little bit more stable so that we can continue to address these other programs and services well. And so sometimes it's kind of getting down to the foundational conversation, and then the most important kind of at-risk other pieces, because there's not been a lot of oxygen left in the room. And it's been kind of an ongoing drink out of the fire hose amount of changes throughout this year. So how do we address those little by little are really kind of the high level approaches. And then some of the specific kind of more granular discussions of that is like for us, 340B, what are going to be some of the definitions of the work requirements? How are we going to approach that? Because Ohio, obviously addressed that and brought that forward before the House bill officially addressed that. And so marrying those things up are really some of the key kind of components that do hit all of us, regardless of what type of service and what type of, area we provide those services in.
So if you were speaking to a policymaker, you would really emphasize how strained the provider community is, and how the kind of uncertainty makes that even more difficult for providers to navigate.
Yes, absolutely.
Okay.
And thank you for summarizing all of that in kind of that way. There's just, unfortunately, we all know that the list has gone from just like, when you go in, you used to talk about one or two things, and now it's like, okay, I have this crucial list of 12 things.
Yeah.
And how do I cut that down to just 3 or 4? And sometimes it's like they're the most dramatic, or they're the ones that, because if the other 9 occur, that, how far are you going to have to cut with staffing, or what service line do you have to peel off and not be able to provide? I mean, those are the types of things that we are and will have to continue to talk about, kind of agnostic of which policy we're discussing with our own respective state and federal legislators.
Yes, got it. Okay, Grace.
Yeah, I'll be brief, but just to offer a slightly different perspective, though I, of course, agree. I would encourage policymakers to think about our neighbors and Ohioans as whole people to the extent that they can, rather than just a Medicaid recipient or just a SNAP beneficiary, and how these systems, changes or not, impact an individual and how they interact with their community, their family, their employer, and to be very thoughtful when we are considering these flexibilities. For instance, CMS just released their initial guidance about the community engagement implementation, and there's a lot of places where states will have discretion and flexibility to implement. And I would encourage policymakers and state agencies to think about the ways in which a Medicaid beneficiary exists within their community, and how flexibilities could, I think it was Rose, maybe it was you, Summer, could be the difference between keeping coverage or not based on those flexibilities, because it makes the path for continuous coverage a little bit easier, and it reduces the administrative burden on county departments, job and family service, who are processing all of these cases and trying to keep up with the workload, and to just reduce the administrative churn for beneficiaries and for county officials and caseworkers who are doing the best that they can with the resources that they have. And so, I would encourage, policymakers and agency officials to think about the complicated web around an individual as they move through their community, and how these changes may affect, how SNAP changes affect your ability to afford medication, for instance, or, you lose coverage, you don't want to pay the premium, you can't afford to pay the premium on the marketplace, you go without coverage, you come to a community health center. Community health centers are facing challenges on their own, and, it's just a complicated web
Right.
across the line.
Well, and I think that's what Rose was saying when she talked about being brought along as partners in the implementation of these policies. Because while there is still some discretion for state officials to make decisions, the big framework for many of these things has already been decided.
Mhm.
So we can move forward and mitigate harm to the extent possible by taking advantage of any flexibilities that are made available to states.
Yeah.
Yeah.
Absolutely. And, our agencies have long histories of engaging the community, and we encourage them to continue to do that as we're looking to understand how these new requirements and how these eligibility changes are going to impact communities. To continue to lean on organizations that are embedded in the community and can bring that community voice to legislatures and state agencies.
Okay. So we have just a couple more minutes here. So I'm going to ask you the classic question that reporters always ask, which is there anything we haven't touched on already today related to the topic of access and affordability that you would like to share with our audience?
I think one of the things that I would just encourage everyone to think about is innovation, right? Like, innovation is a great way we can take some of these challenges that we have to figure out how do we address barriers differently. And in innovation can come new practices. I would also take innovation in a collaborative fashion. How do we come together to address these needs kind of as a group? And how can we potentially be the catalyst that bring collaborations and partnerships together in a non-competitive way? Because a lot of times competition is embedded or is an undertone or is the elephant in the room bright and loud when we try to find opportunities to address needs and gaps for our Ohioans. So really kind of think about what could be innovative ways to lean into these challenges, and what might we discover, because it's so very easy to think about things in terms of the doom and gloom, and the stress level and the anxiety for all of us just rise, and then it just continues to rise. So innovation, collaborations,
Let me just ask a
partnership.
follow-up. Let me ask a follow-up question there, Summer. Can you share an example of something along the lines of innovation or collaboration? Like, it could be from years ago or more recent,
No,
but where
absolutely.
you took a difficult situation and were able to find a creative solution.
Yeah, so some of the things, I'm going to use something that's maybe real world, right? Because of eligibility and work requirements, and if people are going to need to work. But let's say we have some of those fragile states of individuals that aren't quite able to either find a job or get employment, or the timing is part of it, right? Rural situations, etc. So have we thought about creating some volunteer opportunities? Maybe volunteer opportunities are those areas where we can look at how do we help one another? How do we band together for, a social service organization, a homeless organization, you name it, a food drive, etc., and take individuals that maybe need some work requirements and figure out, could we find some volunteer work opportunities for them, or could we frame some things together that would align with the work requirements, particularly to meet those needs and educate our members that are working with individuals on eligibility. So that's one area we've seen. In the community health center space, partnerships with hospital systems or other provider systems, substance use treatment, et cetera, coming together to figure out, and how can we, parse and piece those things together. The other thing is we've been trying to look at like AI, not as a replacement, but what are some opportunities that we can get leaner to look at AI to help us where we know we need more person-to-person interaction because of the cuts and changes that are forthcoming. So those are just two quick areas that come together and think about, like food. See, I could just keep going on. So the next one I'll just think about is food as medicine. How can we get 4-H groups together with maybe an agricultural group or future farmers groups together and identify ways for addressing food is medicine and writing food prescriptions and things along those lines.
Well, that's right up Grace's alley. Grace, so since we only have a couple of minutes left, are there any kind of innovative and creative ideas that Grace or Rose would like to share before we hop off?
Yeah, very quickly, definitely Summer, echo your thought about investing in food and nutrition interventions in this time. But you know, I'm thinking a little bit about, it was not that long ago, we had the unwinding of Medicaid in the state of Ohio and the way that the Department of Medicaid really leaned on community partners in that time of trying to push out information, make sure people were completing their renewal packets. Like that was a time of intense partnership between state agencies and community partners. And I think there's a lot that we could learn from just that experience of how to mitigate harm from changes that, are coming through federal policy that the state has to implement, and the ways that they chose to partner with trusted community organizations. That was innovative at the time and something we could learn from as we're facing a lot of changes from a lot of state agencies and federal agencies.
And I'll just say two things really quick. One is to Summer's point about eligibility maintenance, I mean, we are all going to have to take a much more active role in helping people navigate benefits and navigate their healthcare. And I don't think there's any reason why every organization in town should be making the investment in eligibility maintenance and healthcare navigation. That is an area where I think we should all be working together as a community to say, okay, how do we collectively invest in making sure people can navigate these systems? And then the other thing I would say on the behavioral health side is, we may not have opportunities to engage with people to the extent that we can now. So how do we think about brief interventions and really taking advantage of the opportunities we do have to engage with people to maximize that encounter as much as possible? And so I think there's creative solutions there. It's not ideal, but I think that's we have to start thinking through that framework of really how do we try to do what we can in that moment to help that person, knowing that we may not be able to engage with them to the same extent we were in the past.
All right, great. Well, thank you all for joining us this afternoon. Let's see. So I know we have a few closing slides to touch on before we hop off. We have our poll questions. Thank you again, Grace, Summer, and Rose for being with us this afternoon and sharing your insights. Brian, of course, thank you for highlighting the HPIO publications and data. Again, you can feel free to reach out to either Brian or to me with any questions about those materials. We got to most of the questions in the chat box except for a late breaking one that I'm sorry we won't have time to get to. All right, so let's throw up the poll questions here. I'm sure they're coming, so just hang tight. Okay, here they are. So you have an opportunity to rate our speakers and our panelists and the quality of the forum. or the webinar. Scroll down, there's 10 questions. Should only take you a few seconds to respond to these. Thank you again to everyone for joining us. We know that we're all working hard to understand the policy changes as they happen and convey those changes to the people we serve. We appreciate all of your partnership with HPIO throughout this year. It's actually one of the things that I've been most encouraged about this year is that it does seem possible that new collaborations will emerge out of this time. So we'll be eager to work with all of you in 2026 as we move forward. All right. Well, if you've completed your questions, please have a great day, and we'll see you again in 2026. Take care.